All right, let's continue our discussion. Hypertriglyceride-induced pancreatitis. Triglyceride level over 1,000. I know you'll still see textbooks that say 500. 1,000 is the correct answer. Treatment, no great studies, but we're going to talk. The first thing and most important thing is making the patient MPO. MPO seems to be one of the most important things. And then starting insulin. Heparin is controversial, but heparin can help break down the chylomicrons in the triglycerides. Plasmapheresis is an alternative, okay? It's usually going to do the insulin, and with the insulin, you usually need to give what? Sugar water to keep that warrior, that insulin warrior working, and we'll talk more about that in the endocrine section. Insulin is a very powerful hormone. We forget how powerful it is, and we need you can either basically plasmapheresis, you put a HD catheter in, and the lady comes in with the big machine, and it's usually a blood bank that will do it, and it's super cool because at the end of the day, you have a big bag of fat that you can give to the patient and say, look, this was in your body and we pulled this out. And it looks really impressive. The data hasn't said that this is better than insulin. There's really no randomized control studies between the two. The insulin is easier. Not every place is going to be able to do plasmapheresis. Some places they have trouble placing an HD catheter. There can be harm placing an HD catheter. May not have the access to equipment to do this, but we can do is give them sugar water, get their sugars up, and get higher doses of insulin to force to do all these metabolic things that insulin does, and kind of forces the triglycerides in the cells, stops free fatty acids from forming. Giving omega-3 fatty acids, which are your fish oils, your fibrates, and your statins. So fibrates are the most effective in lowering triglyceride levels in all the hyperlipidemia medications. What are the common side effects of these? Myopathy, which especially when you combine them with statins can make it worse. And if you have to, you can discontinue statins, right, or the fibrates. Remember, the statin is going to increase, the combination between the two can increase your risk of rhabdomyolysis. These are things we have to watch for, but these are things we can manage because these patients are acutely ill. They need to get an endocrinologist as an outpatient follow-up because more than likely they have a genetic disorder that's causing their triglycerides to be elevated, and they're going to probably need a special medication in order to reduce those. This is based off of what their findings are. All right, let's take a look at another image right here. So this patient had hypertriglyceridemia-induced pancreatitis. Look at this, the pancreas is inflamed. I want you to start looking at pancreases. Not like a Dexter thing. I don't want you cutting people open and looking at their pancreas that way. How about we look at them at images, and then I want you to look at what the radiologist said. This patient also had what? Had a really big liver, and this patient had fatty liver disease. So look at this liver. You can kind of see different things in it would be consistent with fatty liver disease versus a smooth, nice liver. So acute pancreatitis, this patient hypertriglyceridemia-induced pancreatitis, hepatomegaly, and had fatty liver disease. This is interpreted by the read by a registered radiologist here in the United States. Okay, we got a next patient here is a 42-year-old male with unknown past medical history and abdominal pain, and he only has slightly elevated triglycerides. He has an elevated lipase. The abdominal pain radiates to the back. He's yellow though. He's yellow and he has a positive Murphy sign. So what is a Murphy sign? Murphy sign is that, and I want you to get used to this physical exam, and we're gonna have a physical exam section coming up, and we're gonna talk about what's important. A lot of stuff that we learned is not good. It doesn't. The Kernig-Berinsky sign, the sensitivity and specificity is kind of garbage, and we kind of use these things as dogma. We need to break away and look at just getting more specific things that have better sensitivity, specificity. Positive Murphy sign is that when I come up here in the right upper quadrant, and I press underneath the rib cage, I ask the patient to take a deep breath in, and while I'm gently pressing, they stop breathing. That's a positive Murphy sign. Do they do a Murphy sign when they do a gallbladder ultrasound? Yes, they do. They put the ultrasound probe right here. They ask the patient to take a deep breath in, and they slowly push in. And if they have that stop and breath, that's a positive Murphy sign. Very sensitive, very important. When you tell your surgical colleagues to say, I have a positive Murphy sign, they should interpret that we have an issue. What is that issue? All right, let's go over the anatomy. I feel our surgical colleagues probably get annoyed with us where we don't know the anatomy as well as we should have. So we have the duodenum right here, and at the duodenum, where all this intersects, is going to be the ampulla of Vader. This is where Darth Vader lives. This is where the ERCP, where they come through the ERCP to come and look for stones. We have our gallbladder and our cystic duct leading from the gallbladder. Now you can have stones in the gallbladder. You have their biliary tree and our hepatic duct, and it comes together to form the common bile duct. And this comes together with the pancreatic duct. So how does obstruction cause infection? So what are the obstructions that we can have or at various points in our duct system? And how do we get infection in there? Is bacteria ascends from the small intestine. Stagnant bile creates a breeding ground because the bile helps flush. Just think of this bile as flushing things out. We can look right here as we're flushing things out into the intestinal tract, and then we poop it out. Stale or obstruction, just like in the urinary tract, is a chance for infection to occur because we're not getting proper flows. And the bile duct pressure increases. The blockage causes the pressure to build up, and this raising pressure can force bacteria and toxins into the bloodstream. So basically, from the duct system into the bloodstream. Gallstone pancreatitis. Suspect when AST and or ALT is 3 times upper limit of normal with pancreatitis. Pancreatitis with features of cholangitis. Cause stones obstructing from the distal common bile duct or at the ampulla of Vader. Diagnosis, ultrasound or CT may show a common bile duct plus or minus common bile duct plus or minus gallstones. Endoscopic ultrasound or MRCP determine if there's stones in the common bile duct. Treatment, ERCP with sphincterotomy. That's where we remove the ampulla of Vader and we get rid of the stones. Removing the gallbladder should be performed in recovery of all cases of gallbladder pancreatitis. All right, let's talk about, we're going to talk briefly about the ultrasound probes. I know we talked about, this is your phase array probe, and this is your abdominal probe. Just getting used to these. I want you to get used to this terminology. And what I want you to do is when you're working, you know what, clinics are going to start having ultrasounds. Like I said, there's a portable ultrasound that you can hook to your phone. There's portable ultrasounds that you can put in your pocket. It's just a matter of cost and you getting used to doing them. I want you at all times to start using these. Even in your clinic, did you know that in Europe, they help diagnose and find out how people are doing on their treatments for rheumatoid arthritis by using ultrasound? The providers use ultrasound in their clinics for doing this because they're looking for inflammation on the joints. You and your clinics can start doing this. You can use these in the wards. Get used to using these because these are great tools where we can see inside the bodies without causing harm. Once the equipment is purchased, you don't want to drop these probes. These probes are very expensive right here. Oh, about $10,000. They have crystals in there, and if you drop them, the crystals get broken. It depends on the manufacturer how much it costs to get these fixed, but you basically have to get them replaced. So right here, we have this patient. We put this probe on the belly. We see this fluid right here. This right here is so up here is the skin, and I want you to imagine this. We put the abdominal probe on here, and then we're looking, this is our intestinal tract. I want you to get in a habit when you're doing this is hold that probe on there for a period of time. Even though you see a whole bunch of space right here, so this blackness is liquid. This black right here is liquid. It has a different frequency that responds back to the ultrasound, so it's interpreted as dark. What happens is sometimes people have very mobile bowels, especially after they eat, and the bowel can come up here. So you think you have all this space, you put the needle, and then you puncture the bowel, and you are not a hero that day. You are not a hero wearing a cape. So let's come over here. This is a 52-year-old male with unhealthy alcohol use disorder with fever, abdominal pain, and distension. This is when we go in and we talk about doing the tap, the paracentesis. We're sticking a needle. I showed you what the imaging looks like. You're going to stick a needle in and you're going to draw out this fluid. And here's another example of the fluid coming out to the vacutainer. So when we know we have ascites from back up, the liver isn't a soft, that soft tissue liver that we may have our grandmother may cook for us and we have to eat, or you buy in a store, or even seen when you did an anatomy lab. the liver becomes hard, it's fibrotic. So that filter becomes clogged, we'll say this, make it simple. And then the fluid backs up in the abdomen. And so we can have, with ascites, we can have decreased blood pressure, reduced renal blood flow, and glomerular filtration. Then this activates because you're going to have less flow to the macula densa in the kidneys, remember that thing? And you're going to have activation of the renin-angiotensin system. So what the treatment is spironolactone furosemide, increase urinary sodium excretion. Patients should get an ultrasound and diagnostic paracentesis with fluid analysis for albumin and total protein, cell count, and bacterial cultures of suspicion for infection. And do a SAG score. Should be calculated, the serum albumin versus the albumin gradient. So the serum minus the ascites gradient, and should be calculated by subtracting the ascites fluid albumin from the serum albumin level. And then we want to restrict sodium less than 2 grams a day in the spironolactone Lasix ratio. Now, this ratio isn't perfect. There's no studies that would prove it, but it just works pretty well. And what are we using this ratio for? If 100 of spironolactone to 40 of Lasix, and you can go up as high as 400 of spironolactone, and so in 160 of Lasix to keep that ratio. What it does is it helps us manage our sodium. So the spironolactone is going to retain sodium, and then the Lasix or the furosemide is going to have us pee it out. Check sodium and potassium levels 1 week after starting these medications or with increasing doses. All right, in ascites, if cannot tolerate diuresis, large volume paracentesis can be used. Greater than 5 liters removed, you should consider giving 25% albumin for each liter removed. The recommendation is between 6 to 8 grams of albumin per liter of acidic fluid removed. Should be administered after. Some studies will say, or some clinicians will do, is they'll have the albumin flowing while you're doing the paracentesis. And typically you're removing more than 5 to 6 liters of ascites. Remember, each bottle of 25% albumin, you have bottles of 12.5 and 25 grams. So if you took out 3 liters, you can give roughly about 25 grams. Remember, greater than 5 liters removed. Discontinue ACEs and ARBs and NSAIDs that decrease kidney perfusion and can exacerbate ascites. So ARBs and ACEs and NSAIDs go away. ARBs, ACEs, and NSAIDs go away. In ascites, you want to go with this furosemide, spironolactone, the spironolactone furosemide ratio of 100 to 40. We take this fluid out and we want to calculate the serum ascites albumin gradient. This is the serum albumin minus the albumin of the acidic fluid. So in cirrhotic ascites, and we use this to calculate what's the reason why this fluid is present. Is it from cirrhosis? Is it from CHF? And then we're looking for infection from this in this fluid. So we grow this out. So we first is use it for diagnostic of why that we have the fluid, and then is the fluid infected? And do we need to give antibiotics to treatment on this? So cirrhotic ascites, you have a high SAG above 1.1. Remember, cirrhotic ascites is protein poor and albumin poor. So here again is we're taking the serum albumin, the albumin from when we draw our labs, and we get it from minus the albumin we draw from our acidic fluid. So if it's going to be a high SAG, meaning that the serum albumin is going to be elevated and then the ascites albumin is going to be low, so we have a high SAG above 1.1. Remember, is that fluid we're pulling in a cirrhotic ascites is going to be protein poor. I want you to think cirrhosis of being poor. I know that sounds bad, that we're hurting people's feelings, but this is how you're going to remember it, is cirrhotic patients, their protein is poor in their ascites. Cirrhotic patient, the protein is poor in their ascites. So you're going to have a high SAG. Due to scarred liver sinusoids, do not allow the escape of albumin. So non-cirrhotic ascites, we're going to have a high SAG and high protein. So non-cirrhotic ascites, so we're going to have, this is going to be a high SAG. So you're going to have the protein in the albumin is not going to be, is going to be higher. So you're going to have your serum albumin and your serum protein in your acidic fluid is going to be high, okay? This will be greater than 2.5, Okay, we'll look at this again. We consider this in right-sided heart failure, Budd-Chiari syndrome, and pulmonary hypertension. So low sag, less than 1.1, the albumin levels in the serum and ascites are almost equal. Now let's talk about the interpretation of the ascites fluid. So first is you're gonna get your serum ascites. That's from your blood work, okay? And then you're gonna draw from doing your paracentesis and you're sent to the lab, and then you're gonna get your acidic fluid. So it's the serum to ascites albumin gradient. So you're gonna take the serum, your serum albumin, and you're gonna subtract your ascites albumin. So if it's greater than 1.1, meaning that the serum, say for example, the serum is 4, and your minus the ascites is going to be 1, so it's greater than 1.1 is 3. This is an extreme example. Then we want to do, so we're going to have portal hypertension. So we come to this portion of the algorithm. So if it's less than 1.1, this means here is that our serum minus our acidic fluid is going to be higher. So this is going to be in non-portal hypertension. Examples would be malignancy, TB, pancreatitis ascites, nephrotic ascites, cirrhosis, okay? So over here, if we have where it's greater than 1.1, we have portal hypertension, and we have our total, then we get the acidic fluid protein. If it is low, remember, protein is going to be low in cirrhosis. Protein is going to be low in cirrhosis, so that's really easy to remember. So if you have portal hypertension, it's going to be greater than 1.1, and then we check the acidic fluid protein, and remember it's going to be less than 2.5. I just want you to think, I know it sounds bad, is people who have cirrhosis are protein poor. People who have cirrhosis are protein poor. If the protein is high, then we come over here to CHF. We consider they would have either CHF, constricted pericarditis, or Budd-Chiari syndrome. And then we want to look at the PMNs. PMNs greater than polymorphic neutrophils, greater than 250, presumed to be infectious regardless of the culture results. Less than 250 mil of PMNs, there's no peritonitis. Treatment of ascites, low sodium intake, okay, because remember, the sodium, the water follows the sodium. Water restriction if serum sodium is less than 125. Diuretics, we talked about the furosemide, spironolactone at 100 to 40 of furosemide. Is this been proven through studies? No, but it just works. Most people follow it. It's not perfect. You don't have to follow that exactly. With a max of 400 spironolactone and furosemide 160. If you have sodium greater than potassium, if you have sodium potassium ratio in the urine greater than 1, urine suggests that you have an effective dose. Why is this dose perfect so far? It's not perfect, but why is it does so well? Is it helps you manage the serum potassium. For diuretic resistant ascites, you need to consider doing large volume paracentesis. You can remove 4 to 6 in a section. You can remove more than that. And remember, after 5, we need to give albumin. Consider 6 to 8 milligrams of 25% albumin per liter removed. Albumin infusion if greater than 5 liters of fluid removed at a time. Rule out spontaneous bacterial peritonitis. So we have increased risk of, so rule out spontaneous bacterial peritonitis. Now, if none of these work, so none of these things are working, what do? Is you consider doing a TIPS. And the TIPS is where you go through the transjugular intrahepatic postural system shunt. Basically, you're going the liver, you're poking a hole through the liver, and you're creating a shunt because the liver itself, remember the liver has become from soft tissue, it becomes fibrosed. We're creating a stent in, we're putting a stent in there so that way it flows. So what are the side effects with this? Increased risk of hepatic encephalopathy. If you think about it, even if that liver filter wasn't great, it still was filtering some. So basically we're having going right through the liver, right up to the brain, and you have increased risk of hepatic encephalopathy. Indications for liver transplant with cirrhosis is a MELD score greater than 15. I want you to start thinking about is whenever you have somebody has liver issues, I want you to start thinking about doing a MELD sodium score. They constantly update these. You want to get the latest score, and it's going to ask you a series of questions so you can correspond with your GI team, and you also can determine, do I need to get this patient referred for a possible transplant?